Products are shown for demonstration purposes only. The American Heart Association does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare professionals in this video do not always use personal protective equipment, such as gloves.
Cardiovascular disease is the leading cause of death globally. From sudden cardiac arrest to acute coronary syndromes to the disabling effects of acute ischemic stroke, cardiovascular disease takes nearly 18 million lives each year.
Cardiac arrest occurs in both men and women of any age, often without warning or soon after symptoms appear.
There is much we can do to improve the outcomes.
This means understanding and activating the systems of care developed by the American Heart Association, integrating community, emergency medical services, the emergency department, and in-hospital clinicians so that everyone is working together to not only deliver better patient care, but also strengthen the chain of survival for future patients.
In addition, implementing response teams in the hospital, referred to as medical emergency teams or rapid response teams, can help prevent patients from deteriorating into arrest. These teams typically consist of healthcare professionals who have both experience in critical care or emergency care and the skills to support immediate intervention for life-threatening situations based on early detection.
These teams are responsible for performing a rapid patient assessment and initiating appropriate treatment to reverse physiologic deterioration and prevent a poor outcome. Some rapid response systems weigh, combine, and score specific physiologic criteria to determine when to activate a rapid response.
These physiologic criteria can include threatened airway, respiratory rate less than 6 or greater than 30 breaths per minute, heart rate less than 40 or greater than 140 per minute, systolic blood pressure less than 90 millimeters of mercury, symptomatic hypertension, unexpected decrease in level of consciousness, unexplained agitation, seizure, significant decrease in urine output, and subjective concern about the patient.
In adults who are experiencing sudden cardiac arrest due to ventricular fibrillation or pulseless ventricular tachycardia, the heart is not effectively pumping blood to vital organs. For example, in the case of ventricular fibrillation, the heart is quivering but not circulating blood. Patients with ventricular fibrillation have a much higher survival rate if they receive immediate cardiopulmonary resuscitation, or CPR, and early defibrillation. A defibrillator should be used as soon as it's available. If there are 2 or more rescuers present, CPR should be continued while the defibrillator is being attached. When necessary, healthcare professionals may tailor the sequence of rescue actions to fit the most likely cause of cardiac arrest. For example, in cases involving drowning, opioid overdose, or other instances where hypoxia is the likely cause of cardiac arrest, ventilation becomes a priority. Scientific studies continue to link high-quality CPR to the return of spontaneous circulation, or ROSC, and to improved survival. Unfortunately, studies indicate that even in a hospital setting, CPR is often inadequate. To address this problem, the American Heart Association requires the use of audio-visual feedback and prompt devices, both during training practice and during testing. The American Heart Association also recommends using these devices during real emergencies for immediate monitoring of CPR quality. High-quality chest compressions maintain blood flow to vital organs, especially the heart. One way to understand the effectiveness of chest compressions is to measure coronary perfusion pressure in experimental settings. As chest compressions begin, it takes several compressions to raise the coronary perfusion pressure to a level adequate to supply blood to the heart. The higher the coronary perfusion pressure during CPR, the higher the chances of survival for patients. When healthcare professionals interrupt chest compressions, coronary perfusion pressure decreases dramatically and remains very low until compressions are resumed. A reasonable surrogate for coronary perfusion pressure is arterial relaxation or diastolic pressure. However, because coronary perfusion pressure or arterial diastolic pressure measurements are not readily available during a resuscitation attempt, healthcare professionals can monitor CPR quality with continuous waveform capnography through an advanced airway or bag mask device. An end-tidal CO2 reading of less than 10 millimeters of mercury suggests that achieving ROSC is unlikely. Healthcare professionals should attempt to improve CPR quality by optimizing chest compressions. To perform high-quality chest compressions, healthcare professionals should compress the chest to a depth of at least 5 centimeters and a rate of 100 to 120 compressions per minute. High-quality CPR is directly linked to improved ROSC and survival rates. However, survival rates decline when compression rates exceed 120 per minute because compressions tend to become shallower as speed increases. The chest should recoil completely after each compression. If these metrics are not met, coronary perfusion will remain low. Chest compression rate is directly linked to improved ROSC and survival rates. Another characteristic of high-quality CPR is minimal interruptions in chest compressions. Studies show that healthcare professionals interrupt compressions far too often and for too long, in some cases spending 25% to 50% of a resuscitation attempt without delivering chest compressions. Chest compression fraction is the proportion of time during cardiac arrest resuscitation when chest compressions are performed. Chest compression fraction should be at least 60%, but ideally, greater than 80%. Switching compressors every 2 minutes, or earlier if fatigued, can help to keep the quality of chest compressions high, because it helps avoid the fatigue that can directly impact depth and rate. Finally, avoid excessive ventilation. This includes both ventilation rate and volume. Excessive ventilation can not only cause gastric inflation and resulting complications, but it also can increase intrathoracic pressure, decrease venous return to the heart, and lower cardiac output and a patient's chance of survival. For patients with cardiac arrest, appropriate tidal volumes are evidenced by a visible chest rise and can usually be achieved with 1/3 to 1/2 of a squeeze of an adult ventilation bag. Defibrillation should be integrated early within high-quality CPR. Healthcare professionals should initiate CPR starting with chest compressions and use the automated external defibrillator or manual defibrillator as soon as possible for the best patient outcomes. Understanding the science behind your resuscitation efforts is key to improving your life-saving skills. Knowledge combined with practice is what will ultimately improve the quality of your response in a cardiovascular emergency.